Awesome. Hello, everyone. I really do hope my background is not too loud. I am in East Africa, in Rwanda, and I'm trying to make this as audible as possible. So please do forgive the environment noise. Good afternoon, everyone, and thank you for joining us for the Gender COP by Hub Cymru Africa. Our aim with this time together is to raise awareness and knowledge of reproductive health challenges in Africa with a specific focus on Kenya. Our guest speaker will be Betty alongside Alice. We will focus on reproductive health rights in Kenya by highlighting the challenges in the country and the importance of reproductive health alongside this. With global solidarity at the heart, Betty, alongside Alice, will share recommendations on how Wales can stand for hub for reproductive health. And yeah, it'll continue on to a question and answer session. Please can we move to, yeah, we're already on the next slide. So this is the layout of the session of today. Yeah, we can move to the next slide. To start, I will share an introduction and overview that will look at reproductive health challenges in Sub-Saharan Africa. Oh, sorry, if we could stay on the slide before you. I would like to start with a brief introduction of myself. My name is Isimbi. I am passionate about women and reproductive health on the African continent. I've conducted two qualitative primary research studies on the determinants, influences, and perceptions of family planning use among women in Sub-Saharan Africa, specifically looking at family planning use with rural women and sex workers in Uganda. Reproductive health is a term that many of us may know very well. Despite this, I would like to begin with a definition put together by the World Health Organization. Reproductive health implies that people can have satisfying and safe sex lives and that they can reproduce and have their freedom to decide if, when, and how often to do so. Please also do notify me if it's getting too loud around. I'm very sorry about that. I would like us to take a moment to reflect on the significance of this definition that many women and men do not have access to. They do not have access to the freedom of choice, the freedom to decide when, how, and how often to do so. This makes many limited to the knowledge of their reproductive systems, their rights, and the services that are available to them. I think it's important to briefly look at what makes education of reproductive health a challenge today in Sub-Saharan Africa. A research study by an African researcher called Wangati, she published a paper in 2020 highlighting the reality of most communities in Sub-Saharan Africa. She begins by emphasizing two types of communities that limit reproductive health knowledge, being religious and or traditional communities. Religious communities tend to direct individuals to premarital sex abstinence, monogamy, and cruel positions on sexuality. Such practices in religious African communities contribute to limited education for youth on sexual rights, reproductive knowledge, and information. Many communities in Sub-Saharan Africa view reproductive health as a topic of discussion that is appropriate for marriage ceremonies alone. Many youth are not informed of reproductive health, so it is until marriage ceremonies that they are involved in these discussions. Many communities also hold a patriarchal lens where men are assigned dominant positions and women are expected to be submissive or compliant. In several African communities, education on gender equality tends to conflict with community practices and beliefs. Different people groups on the African continent have had a similar method of sharing knowledge on reproductive health for several years, and this historical method is still practiced today. These techniques are inclusive of family members such as aunts, uncles, and grandparents being the only source of knowledge for reproductive health. They tend to refrain from parents or medical professionals being the main holders of this information. These family members have been encouraged to use storytelling, circumcision songs, and traditional crafts as ways to inform marriage, people who are going into marriage about reproductive health. Next slide, please. Thank you. With a little context on what makes reproductive knowledge and education a challenge in Africa, let's look at the key areas compiled by the World Health Organization on cruel reproductive health facts in Africa. Maternal health ratio is defined as a number of maternal deaths during a given time period per a certain figure of live births during the same time period. What does maternal mortality ratio look like in Africa? The MMR in the African region has declined from estimated 857 per 1,000 live births in 2000 to 525 deaths per 1,000 live births in 2017. Despite this progress, this is still far from global target of 140 maternal deaths per live births, and progress remains unequal across countries. What does the contraceptive prevalence rate in Africa look like? The contraceptive prevalence rate, modern methods among married or in union women in Sub-Saharan Africa increased from 14.7 in 2000 to 27.9% in 2019. However, only 52% of women in this group have their need for family planning satisfied with modern methods. So there is still a desire for women to meet a contraceptive prevalence. What about abortion in Sub-Saharan Africa? Abortion can be provided legally upon request with no justification requirement up to a certain pregnancy level in only 4 countries in the African region: Angola, Cape Verde, Sao Tome and Principe, and South Africa. Consequently, most of the abortions done in countries within the African continent are illegal and unsafe. It is estimated that 5.2% to 17.2% of maternal deaths annually in Sub-Saharan Africa are due to abortions. We will also be looking at FGM. What about FGM? Let's first start with a brief definition of FGM. FGM is the female genital mutilation, which comprises of all procedures involving removal of external female genitalia or other injury to the female genital organs for non-medical reasons. Most often, FGM is practiced on girls and women under the age of 18. FGM remains a problem in the African region, particularly in West and Eastern regions. Approximately 95% of females aged 15 to 49 years in Guinea have undergone FGM. Lastly, what can we quickly know about HIV in Sub-Saharan Africa? Approximately 25.7 million people are living with HIV in the African region. 1.1 million new infections were recorded in 2018. About 79% of pregnant women living with HIV received antiretroviral, for prevention of mother to child transmission of HIV in 2018. We can move to the next slide. Thank you. Now that we've had a look at 6 crucial topics on reproductive health conversation in Sub-Saharan Africa, I believe it's always good to get firsthand experience of an individual facing challenges with reproductive health and rights. This is an account of a woman by the name of Ivy who lives in Uganda, and this is her experience with reproductive health. I tried to use family planning pills, but the day I got them from the clinic, my husband made me throw them away. I knew I needed to stop my children for better health and, for me to be able to look after them. But because my husband refused, you can see how I had 4 children in our first 5 years of marriage. That's what she meant. Yeah. Next slide, please. Before I hand it over to Betty to take us through the reproductive rights in Kenya, I'd like us to get an idea of some of the influences of reproductive health choices for women in Africa. The first point is the high value of motherhood. Second point, unprotected intercourse is still viewed as a sign of fidelity and loyalty. Misconceptions about family planning, where many male partners believe it encourages unfaithful partners. The fourth point is that there's access and awareness of reproductive health knowledge and services. So there's low access and there's low awareness of reproductive health knowledge and services. The fifth point is that many are unaware of their HIV status, and this causes higher reckless transmission. The sixth point is that gender norms determine fertility desires and limited family planning use. Infertility, the seventh point is infertility is still a source of sadness and shame because many women still gain a sense of identity from their role of a mother. The eighth point is economic independence is still a huge issue. The ideology that men control decision making and head the home is still the leading norm. The ninth point is that household wealth is also a huge factor in reproductive health choices for women. So depending on the economic status of a home, that can determine whether they're on reproductive health choices or not. The 10th point is that women fear reproductive health services and knowledge of rights they believe knowledge of rights will cause loss of intimacy with their partner. So they believe less knowledge is more attractive for their male partner because they're not trying to outsmart them. Sorry, I just have 2 more points. Many communities also struggle with insufficient daughter and mother dialogues about reproductive choices and services, leaving many women informationless. So the mother-daughter relationship is a huge factor to where women are today. So many young girls grow up and they don't have information about what decisions to make with their reproductive choices. The last point is that cultural practices, cultural values, belief, and religion play a huge role in how women interact with their reproductive choices or rights. Can we please move to the next slide? When it comes to reproductive health and reproductive rights, what is the case in Kenya? We will now be handing over to Betty Ngeno, who is a human rights advocate and gender specialist based in Kenya. Thank you so much.
Thank you so much, Isimbi. I hope you can hear me. Okay,
yes.
sorry.
Yes, we can hear you. Thank you, Betty.
Okay, sorry, I'm not going to put on my video right now because of the connectivity issues. As Isimbi said, my name is Betty Ngeno. I'm a gender and development specialist from Kenya and human rights advocate. I'm going to take you through the reproductive health rights in Kenya as it will be shared in the slide. Next slide, please. Reproductive health issues here includes HIV/AIDS, family planning, sexual health, that's sexually transmitted infections, abortions, sexual violence, adolescent reproductive health, sexuality, female genital mutilation, and maternal health. Next, please. Access to family planning services information. Kenya has made considerable progress in improving sexual reproductive health. However, the unmet need for family planning services has remained high. Poor rural women and girls, those living with disabilities, and those who have recently delivered are especially affected. Recent Family Planning 2020 report shows that 18% of women who want to stop pregnancy or stop having children altogether don't have access to modern contraceptive information and services. The youth are the most vulnerable, facing considerable barriers to accessing sexual and reproductive health information and care. Next, please. According to a United Nations Population Fund report, 1 in 5 Kenyan girls aged 15 to 19 have already had a baby or pregnant. This exposes them to a myriad of risks during childbirth, dangers of unsafe abortions, and disruption to their education and future economic prospects. In addition, female genital mutilation remains a key challenge in improving sexual reproductive health rights and consequently exacerbates poverty. These cultural beliefs and practices around childbearing and decision-making authority among African societies is impacting on access to family planning services. Most women practice family planning services without the knowledge of their husbands. Next, please. The male resistance to the use of family planning is attributed to their firm belief that children are God-given and that is only God who can determine the number of children one should have. In such communities, for instance, in the Sabaot and Bukusu of Western Kenya and Muslim communities in Northeastern, women are required to give birth to as many children as they are able to conceive without exercising choice. It is also notable that it is among the communities that girls are married off early in life and therefore women tend to have a longer reproductive lifespan. Polygamy also is a common practice in these communities and wives are expected to compete for the man's resources through childbearing. Next, please. The cultural norms places decision-making authority regarding reproductions on the man and in some cases, the mother-in-law who greatly deny women the right to access family planning services. Most communities in Kenya, it is the man who decides whether or not the woman should use family planning. Similar authority is vested on the mother-in-law where she determines if and when their daughter-in-law can use contraception. The mother-in-law also makes decisions as to where the daughter-in-law can obtain healthcare services. For instance, among the Kiriama, Kiriama is one of the communities here in Kenya. Kiriama culture puts a lot of power in the hands of mother-in-law, who is responsible for giving guidance on which traditional path attendants, which is normally known as mkunga in Kiswahili, to be seen and what traditional herbs are to be taken. Next, please. In other cultures, the use of family planning is perceived as an attempt to conceal unfaithfulness and extramarital relations. Hence, A married woman or man seeking family planning is scorned, affirmed, and viewed as a person of low morals or as a commercial sex worker. For instance, use of condoms are viewed as to be used on prostitutes, and this at times leads to quarrels at family level, which some women think that their husbands who use condoms are unfaithful, and men think that women who use contraceptives and condoms are up to no good, since they can cheat on their husbands without being caught. Next, please. Why reproductive health is important for Kenya? Poor reproductive health of young people is a major public health concern, as they represent 26% of the population in Kenya. 14% of the maternal mortality and 11% of all new births globally are females in age between 15 to 19 years. 95% of births in adolescents occurring in developed countries. Among the youth, for every one man infected with HIV, there are 4 women, which is 60 to 80% of African women infected with the virus has been through sexual intercourse. An estimated 1.3 million adolescent girls and 780,000 adolescent boys are living with the HIV virus worldwide. These negative consequences in reproductive health occur presently among young people in Sub-Saharan Africa, born in social plagues of poverty, HIV and AIDS, and poverty. Next, please. Challenges. What are the challenges of accessing these reproductive health rights in Kenya? The first one is challenges include vulnerability to early and unintended pregnancy, unsafe abortion, female genital mutilation, child marriages, gender-based violence, malnutrition, and reproductive tract infection, including sexually transmitted infections. Next, please. What's being done to address reproductive health issues in Kenya? The first one is advocacy against gender-based violence. This is engaging in advocacy efforts to prevent and address gender-based violence, ensuring that individuals are informed and empowered to protect themselves from sexually transmitted infections. Second one is adolescent sexual and reproductive health. Focus on addressing the challenges faced by adolescent girls and the youth, such as lack of information about sexual and reproductive health, teen pregnancy, and new HIV infections. Next, please. Number 3 is integrating sexual and reproductive health services within universal health coverage. The government of Kenya is integrating sexual and reproductive health services within universal health coverage. It is aiming to improve access to priority services and minimize the incidences of STIs, that is sexually transmitted infections, HIV, and other reproductive health issues. Number 4, community engagement. Community-based programs encourage active participation, fostering a positive environment for sexual and reproductive health discussions. Through community engagements, it aims to reduce stigma, improve awareness, and promote positive health-seeking behavior. Next, please. In conclusion, in Kenya, despite the various international, regional, and national frameworks that seek to address this phenomenon, it is particularly noted that in spite of the efforts to prevent sexual violence in Kenya, various perpetuating factors persist, such as the cultural practices and gender inequalities. Wales community can support reproductive health challenges in Kenya by engaging in advocacy activities and also implementing programs that create awareness about sexual and gender-based violence and its mitigation measures. Also, Wales community can develop programs that target youth and school-going children to educate them on harmful cultural practices and safe sex practices. Next. Thank you.
Great, thanks very much, Betty and Isimbi. Yeah, we've learned a lot from you, and I was really hoping that we would have been joined by Alice by now, but I'm not sure whether something came up or it's a connection issue, but unfortunately she's not here yet. I would suggest we just address any questions if there are any for now, and see whether she will be able to join before we before the meeting will end. So are there any questions to Isimbi or Betty from the listeners?
Could I make a comment, please?
Yes. Hi, Angela. Thank you. Yeah.
I've been working in the field of maternal mortality for 18 years now. And currently our focus is in Sierra Leone, where when we started traveling there in 2009, the maternal mortality ratio was 2,100 per 100,000 live births. The latest figure is 443. And the government attributes that to predominantly the fact that we have provided a large amount of the medication which prevents or treats maternal postpartum hemorrhage, the biggest killer, and also the skill sharing training visits that we have provided via our British midwives who've travelled across, and we've done training and we've identified local midwives, experienced midwives who've now become champions, and they are now going out into the far reaches of the country and actually delivering the training to their own colleagues. And the Sierra Leonean government has attributed that to what we've done. Now, it's not about blowing my own trumpet, it's just the fact that it is relatively easy to reduce these numbers. The fact that the maternal mortality numbers across the world are still hovering around 300,000 is a disgrace, and it shows that this very important subject has dropped down the priority for governments. And I'm particularly concerned about the fact that Nigeria, nothing is happening there. The numbers are still in excess of 58 to 60,000 deaths a year, and that nothing seems to be happening there. So it is possible to do this with the right political will, the cooperation of the governments, the resources, and that was one comment. And just to say that Gambia, we had a request to start helping Gambia, and then we were informed that the government there were reversing the law on FGM and allowing it to happen. But everybody else is moving in the opposite direction. Gambia is reversing it. And so I, through a local contact here who is traveling to Banjul next week and has a good contact with the government, to say that we are not prepared to work with a health department that is thinking along these lines in relation to, there's no point in us trying to save lives if their actions are going to put women at risk. It's crazy. So and I also just wanted to shout out for a project that's happening in the School of Pharmacology here in Cardiff with Professor Birchall, a microneedles project funded by the Gates Foundation, which allows women to self-administer a contraception hormone directed. It doesn't need skin cleansing, there's no bleeding, there's nothing. He's working on that, and will be moving into the human trial stage fairly soon. I spoke to him on Friday because I keep getting asked, when is this coming? So there is a lot of work, and it's led by Prof. Birchall's team in Cardiff, which is great news. And he's got ongoing funding from the Gates Foundation to provide this. So we could be trailblazers in Cardiff with this project, which, as I said, it's a little device you peel open and the women put it on the skin, press down, these microneedles go into the skin and deliver enough contraception for 6 months. So I will keep people up to speed with that because I'm in regular touch with him. but it's super. It could be a couple of years, but it's something that the women have control over. They can do it themselves. It's fantastic. So sorry it's a bit lengthy, but I thought I'd just share that with you.
That's all right. Yeah, thanks a lot, Angela, for sharing. That is indeed very, very interesting to hear, and very good to hear that you know, certain things are happening and there is progress and ideas, and especially those fairly probably affordable solutions that just need need to be made available and advertised, I suppose, that more and more will adopt them. Yeah.
Yeah. I'd be very happy to present Sierra Leone on an event like this if you want in the future at some time. By all means, I'm happy to do that.
Okay, great. Yeah, definitely. Yeah, we'll keep that in mind and be in touch. We're always definitely very open to hear from practitioners about their
Julian knows
experience.
about us. He's been like a mentor alongside us, helping us, and been great help. So yeah, the hub's been fantastic.
Oh, that's good to hear. That's really good to hear. Yeah, I suppose this is such a huge, complex field, right? That yeah, we could have probably a whole series of events just in relation to that, and then you'll always find that it's all interrelated and connected, and yeah. So even more interesting to hear about approaches that address the whole complexity. But yeah, I don't know. Are there any other comments, or Isimbi? Sorry, yeah, over to you.
No, I just have a comment on what's just been shared by Angela. The microneedle sounds amazing.
You're a bit faint, Isimbi, you're a bit faint.
Oh, can you hear me now?
Yeah.
That's better?
Yeah.
So sorry.
I love the glasses, by the way.
Thank you. Yeah, I can yeah, I love glasses that speak for themselves. Yeah. But yeah, that's such a fascinating idea, the microneedle and the long-term solution in one. I think I was just thinking in terms of acceptance in more rural communities or uneducated communities, and how to engage such spaces, you know, with because already things as simple as pills took some time to like recommend, and took some time to be accepted. So the microneedle, I was just thinking how communities might receive that, and I don't know if Betty has any thoughts on that, but I was just thinking in terms of that being a possible challenge in more more uneducated or more rural communities.
Thank you, Simbi. Is there anything you'd like to add to that, Betty?
Yeah, sure, I can say something. Thank you, Angela, for that. It's something great that but what's happening here? Most people are living in rural areas. They don't have information on what's happening, and also there are a lot of cultural beliefs, a lot of gender norms, gender stereotypes, and I think they need a lot of education. They need a lot of information. Maybe before that, if they can, I don't know what can happen, but if they can get people to go on ground to educate not only women but both men and women on the importance of the family planning and practicing on the how that how those things affect the education and even the future of their children. Yeah.
Could I come back in on the education point? One of the things I've traveled quite extensively across Africa. And one thing is I'm aware of the emphasis on the number having boys, and that in the event that the women don't give birth to boys, they are blamed. So wherever I go, I always try my best to make people realize that it's actually the father of a baby who determines whether it's a boy or a girl, not the mother. And I sort of took a major risk when I was in Somaliland, speaking to a mixed audience. and said, do you realize that it's the father of a baby who determines whether it's a boy or a girl? And I was met with a sea of blank faces, and I asked the men, who were huddled in a group, probably scared of what I was going to say, and I said to them, do you realize it is you who determine whether the baby is a boy or a girl? And they shook their heads. So I explained in quite graphic detail how a baby becomes a boy or a girl, and they were very uncomfortable. But I do think sometimes that we let these beliefs, understandings continue because we won't challenge them. And we have to challenge them and let people know. People here in Cardiff don't know, groups I've spoken to don't know that, and the women's lives are being put at risk for this relentless wish to have boys. And then they're set aside, or they died because they've tried and they failed. And yet it's the dad who determines whether it's a boy or a girl. And I think an education campaign of some sort, informing men and women that it's not the mother's fault if they don't have boys. I don't know how possible that is. I've suggested it here everywhere that I go. I mean, in Liberia, they've got posters at the side of the road about rape, about domestic violence, about contraception. And this is one thing that these countries seem not to want to address. And I think it would be quite significant, really, and make the women feel better too.
I agree with that.
Dilla, sorry, you put your hand up.
Yes, I'm really interested in the discussion today because I work predominantly at the moment, although we work all over Africa, we work predominantly in Angola and Sao Tome and Principe. And, these are the sort of factors that we come across when we go in to do our menstrual health and our education sessions in school for young girls. It's, as you say, the basis that we're understanding is that we deliver in the national language initially in Portuguese. However, the education of these young females and adolescents the literacy is so low and the comprehension is so low, we often have to redo the session again several times in many different tribal languages within the same cohort. So, and as you say, overcoming those prejudices that we get about, cultural beliefs, we try to address them, every time we go into a room, every time we come across, the idea that we have to get pregnant early. In one school we were at last year, 73% of the girls leave school pregnant or have been pregnant by the time they're extending their education into 18 when they should have finished their primary education by 11. But realistically, in most cases, it's 15, 16. They're married off in those cases, and ideals like that. One thing I can say, I've noticed the latest statistics coming out of Angola, infant mortality is actually declining. We are getting on top of that. And also, this is a good thing, but back to Angela's, the idea of the microneedling. We've got this lovely hospital in Luena. Contraception is free. However, the bias is there against taking home packets of pills, etc. And we're trying to overcome that. We're trying to, address those issues. We're working with a partner this year who have taken condoms out of their workplace, and they're now trying to put them back into their workplace to, encourage the choice or the freedom of choice. So I fully support what you're saying, Angela, Betty, those prejudices, those ideas, as I say, but keeping those girls in education so that they can make those choices for us is our focus. And, hopefully we will start to develop a healthier population and have more equality amongst our girls and females out there. The microneedling sounds great to me, because I think if they came into the hospital to have their babies and they were given the option of a microneedle without the husband even being in the room, I know it's then the choice is one-on-one, and they can go away for 6 months and know that they're going to have that, that would be amazing for them.
Particularly if they've had a cesarean section birth, because in this country, as you know, women are advised against becoming pregnant again. after section for 2 years. But in these countries, there's enormous pressure on women, and that in themselves will put these women's lives at risk because of the risk of ruptured uterus. If they become pregnant too soon, they don't get to the hospital and they're dead. So it's giving the women a little bit of control. And I did see in Sierra Leone once a midwife in a marketplace with a little fridge and with the depot injections in there, and she was talking to women in the marketplace who had new babies, young babies, and said, do you want more children yet? And ultimately what she said, well, I've got this injection here that will protect you. Now they're supposed to ask the husband's permission, but of course they don't, which is fine by me. So some of the midwives over there are actually being very innovative in what they're trying to do, but we need it scaled up, really. It's scaled up massively to be effective. But there's lots of good ideas and got a lot of good work going on. We just need to scale it up, and I'll feed back to Prof about his microneedles project. He's about to start the human trials, I think, on it. It's the same drug that's in the implant, that they put in under the skin. It's the same drug, it's just a different delivery method. So it should be without problems. Sorry, I'm chattering a lot, but Julian will know that's me. Can't help it. Sorry.
Julian.
Thank you. I wanted to ask a little bit, particularly Betty and Isimbi, and it's a bit of a tortured and complicated point in some ways. So why not? We've got 10 minutes. But just to think about the kind of journey that we've been on in Wales, the work that we try to do in Hub Cymru Africa, particularly about wanting to be led by African partners, led by African communities, and to be moving away from the kind of strains of cultural imperialism of like, we know best, you don't know. Because this is one of those areas that I think is more difficult than from that point of view than working on adapting to climate change or developing sustainable livelihoods or putting in education systems, because actually quite a number of these issues don't relate to a lack of resource or education or information. They relate to the attitudes and beliefs that people have within communities. Now, I can see, I think with all of these things, we can see that there are people who are suffering. We can see why that is, and we can see that we have some ability to take action. But the question for me is really is how should we approach that? How should we approach that as well-meaning white liberals in Wales, and how to think through those issues of what right do we have to engage in communities, and say we don't believe in FGM, we don't early marriage, these things are wrong. There you go. That's the essence of my question is, how can we approach that sensibly and tread that path?
I don't know if I can start, Betty, then I'll hand over to you. Definitely, I think integration, like some sort of like coming into the community, not with tips for help as the first conversation. So I think a lot of communities take it very well when you understand the way they think. And even if it's a wrong way of thinking, I think it would be good to understand the way they think. And that doesn't mean being there for 2 years, but, having a few sessions and understanding, okay, so what is your cultural view of this? And having more of a conversation type of approach. I think people take that very well, more than the workshop and almost teacher-student perspective. But I believe a lot of African communities are very welcoming, and I think Angela and Dallas can even back me up here. A lot of African communities are welcoming. So when you are engaging with them, they're very interested. I don't know if, yeah, I don't know how my internet is acting, but yeah, sorry, I don't know if I froze there.
I think you're fine. Thank you.
Yeah, yeah. So I think that that's like the heart of what I would like to share. Um, yeah, I think there's a lot to learn and understand why cultures perceive the things that they do, but at the same time, a lot of youth in the cultures are also ready to make those changes, and a lot of also older people in the community are like, this cannot be the way of doing things anymore. So there are people who want who want change. So yeah, I think Betty, I don't know if there's anything to add.
Thank you, Isimbi. I think you have noted what I wanted to say, especially on the culture part. Being able to understand their culture. What does their culture say about women? Or what does their culture say about FGM? Because here in Kenya or in Africa, there are cultures that believe that you become a real woman if you undergo FGM. Yeah. So if by understanding really what their culture wants, that's why really help. Thank you.
Great, thank you, Betty. Okay. Any further comments about that? Delith, yes.
Sorry, I've got a lot to say today. No, I was just going to say our first point is always to recognise our partners in that sense, and we are guided by them on cultural practices. And we are very fortunate that our partner in Angola is male, and he is an educated individual who believes that women should have these equal rights, and therefore we take it from, we are guided by him and his body, as in the trustees, etc., of his charity, and they are really, as you say, we've engaged with the Director of Rural Education, the public health supervisors, and those are the people who really want to see the change, because they understand that these drastic increases in population is not sustainable in these rural communities. I mean, we are taught we work in the extreme of rural communities, and they really are, they're dealing with landmines. The last thing they need to deal with is lots of children running around and, unaware that they are living in a very, very difficult area. So, it is really about first step, engaging with our cultural partners and being guided by them.
Thanks, Delith. Yeah. It all sounds very, very reasonable, and definitely as the really crucial point to use a conversation approach and to really make it a priority, the recognition, and finding local people who can be the bridges, I guess, the people that will trust you, hopefully, and then therefore advocate. Are there any other questions related to this, or other points to make? It's a shame we haven't heard from Alice now, but yeah, Isimbi.
Sorry, I
Please.
just wanted to add one more thing. I think that this is an area that needs a lot of research. There is a very low research on reproductive health on the African continent, and I think that's why I was so drawn to that area. So just getting figures and getting experiences of women, and how what their relationship is with their reproductive health and choices. Yeah, and is essential, because then people start to get an idea of how to approach it, and which direction to take. So just wanted to add that. Yeah.
Thanks for the point, Isimbi. Yeah, it comes down to money, probably, right? That is put into the research, and yeah, how it's being made a priority. But yeah, and I wonder to what extent it's a generational issue, and whether there is really a hope that the younger generations will more recognize it as a problem, but also maybe have a better access to information. And yeah, maybe via social media or other channels that are available nowadays. Yeah, so Alice is here now. It's obviously we're almost at the end of our meeting. Yeah, I don't know. I don't think we should massively overrun. I don't know how available you are.
No, I think we've done it, haven't we? I think maybe a little confusion with time.
Yeah.
Or maybe it was just a connection issue.
Yeah. Very possible. Well, okay. Hi, Alice. Sorry, we've almost at the end of the meeting. Well, thanks very much for joining us. I think yeah, we're not in the position to overrun, but yeah, I'll be in touch. And thanks very much to Isimbi and Betty for your presentations and for all comments and contributions to this topic today. It once again it's been recorded, so you can always come back, and I do hope we can continue the conversation in yeah, one or the other way. Okay. All right.
Thank you, everybody.
Thank you, and
Thank you so much.
have a great afternoon.
Bye.
Bye.
Thank you.
Bye.
Thank you.
Bye,
Thank
everyone.
you, everybody.